Hi, my name is Kenny Morford. I'm a general internist and addiction medicine physician at Yale School of Medicine. I provide primary care and addiction services at an opioid treatment program called the MAUD Foundation. And I also care for patients in the hospital on the Yale Addiction Medicine Consult Service. Today, we're discussing behavioral tools that you can use in your office to support patients with alcohol use disorder. While medications for alcohol use disorder are both vital and effective, behavioral interventions play a critical role in helping patients meet their treatment goals and to improve treatment retention, engagement, and medication adherence. Many clinicians feel they don't have the time or skills for complex psychotherapy, but there are some practical, quick, and high-yield behavioral tools that can be adopted in a busy primary care setting. By integrating these tools, we can help patients identify triggers for alcohol use and develop skills to manage cravings in real time. Managing cravings is often a challenge for individuals with alcohol use disorder. Craving, defined as a strong urge or desire to drink alcohol, is the physiological and psychological response to alcohol-related triggers. Triggers may take the form of life stressors, such as a strained personal relationship or losing a job, or exposure to alcohol-related cues, like driving past a liquor store. To help patients reduce and manage alcohol cravings, it's important to identify these triggers and develop strategies to address them. One of the most well-established behavioral treatments for alcohol use disorder is cognitive behavioral therapy, or CBT. The theoretical framework underlying CBT is the cognitive model, which describes how people's thoughts and perceptions influence the way they feel and behave. While individuals often cannot change how they feel once an emotion has taken hold, they do have the ability to change their thinking patterns, which can influence the intensity and duration of their feelings and ultimately their behaviors. CBT is especially useful for preventing and addressing a return to alcohol use by helping patients recognize triggers for drinking and then develop ways to anticipate, avoid, and cope with those triggers. Now, it's important to note that CBT typically involves 8 to 12 structured 1-hour sessions each week with a trained psychotherapist. With the realities of healthcare, this is likely out of scope for most primary care clinicians. But there are some CBT-informed tools that can be easily integrated into your practice. The RAC framework offers a straightforward way to incorporate core components of CBT into primary care, as well as other generalist and subspecialty settings. RAC stands for Recognize, Avoid, and Cope, though you may also encounter it described as Reinforce, Anticipate, and Cue. For this video, we'll be using the Recognize, Avoid, and Cope formulation. First, we want to help patients recognize their triggers for alcohol use. These often involve people, places, and things that are related to alcohol and can lead to a craving. Once we've identified the triggers, we can explore how those triggers can be avoided. And if they can't be avoided, we can help patients develop coping skills to prevent returning to alcohol use. Now, one strategy that I use in my own practice when a patient returns to drinking is to perform a behavior chain analysis. These can be done pretty quickly. It usually takes me about 10 minutes, and they can be very helpful to identify triggers and potential coping strategies. The purpose of a behavior chain analysis is to increase awareness of the sequence of events that leads to a particular behavior. By examining this chain, you can identify triggers and pinpoint where a link or a maladaptive behavioral trigger could have been broken to prevent the drinking episode. The example I'm about to share is adapted from a behavior chain analysis I did with the patient after she had a return to alcohol use. So here's how it works. When a patient has a return to alcohol use, I start by asking them, what led you to drink? The goal is to understand in a curious and non-judgmental way what they think triggered their alcohol use. I then get out a piece of paper and I draw 2 circles, one with the stated trigger and one with the behavior. In this case, the patient said thinking about her mother on the anniversary of her mother's death led her to drink a bottle of wine. But the reality is, a lot happened between that thought and the behavior of drinking alcohol. So I draw a bunch of empty circles, creating a chain, and then we start filling them in together. I ask, what happened after you started thinking about your mother's death? She said, I felt lonely. Then what? I texted my son, but he didn't respond. Then what? I drove home from work. I saw a liquor store. I stopped at the liquor store. bought a bottle of wine, and then I drank that bottle of wine. Now we have a clearer picture of what led to her drinking. We can analyze each part of the chain to identify what led to the behavior and what delayed or could have prevented it. We identified feeling lonely and seeing the liquor store as two of the major contributors to her drinking. If these were removed from the chain, she may not have drank. And we also identified texting her son as a coping strategy that delayed and could have prevented her from drinking if he responded. Pulling this information into our RAC framework, we've identified 3 triggers to recognize: thinking about her mother's death, feeling lonely, and seeing the liquor store. We identified an avoidance strategy, which was to take a different route home that doesn't pass by any liquor stores. And for a coping mechanism, we identified making a list of 3 or more people to call or text when feeling lonely in case the first person doesn't respond. Now, in addition to these targeted coping strategies, many patients can benefit from a mindfulness approach called urge surfing. Often, patients feel that an urge to drink will continue to grow until it becomes unbearable, forcing them to give in. Urge surfing teaches them that a craving is like an ocean wave. It starts small, it builds to a peak or crest, and then inevitably it subsides. Instead of fighting the wave or being swept away by it, the patient surfs it by acknowledging the urge without judgment, focusing on the breath and physical sensations, and then waiting for the wave to pass, knowing that the discomfort is temporary. It can be helpful to teach patients how to urge surf by going through a worksheet together that guides them through the various steps. And then you can give them a physical copy to take home with them for later reference. We've linked to a downloadable urge surfing worksheet in the description that you can use with your patients. As you can see, this mindfulness approach fits into the COPE part of the RAC framework by giving a patient an immediate skill to use when triggers are unavoidable. Mindfulness strategies like urge surfing can be powerful tools for patients to use in the moment to break a link within a behavior chain. By using mindfulness, individuals learn to pause and observe their internal experiences without immediately reacting to them. This mindful pause disrupts the automatic sequence of thoughts, feelings, and behaviors, creating space to choose a healthier, more effective response instead of following the usual chain toward an unwanted or less healthy behavior. Integrating these tools doesn't require a 60-minute therapy session with a specialist. Even 10 to 15 minutes of discussing triggers and exploring avoidance and coping strategies can provide a patient with tangible skills to achieve their goals and ultimately improve their treatment engagement, retention, and adherence to medications. For your next patient with alcohol use disorder, with ongoing cravings or return to alcohol use, try mapping out one behavior chain analysis or counseling them about urge surfing.